Good morning, everybody. Welcome to the Subcommittee on Worker Continuation of Care. Today is Friday, October the 14th, 2022. Let's see. So the first item on this morning's agenda is a review of the minutes from the September 16th and September 22nd meetings.
Matt, have you had a chance to review both?
Yes, and I am fine with approving both of those.
Okay.
Do we need to make a motion?
Yeah, go ahead. If you want a motion, I'll second.
I will make a motion to approve both sets of minutes.
I second. And all in favor? Aye.
Aye.
Opposed? Abstentions? Motion carries. Teresa, thank you.
You're welcome. Good morning, Patrick. We just started. Let's see. The second item on the agenda is really introductions, which I don't think we really need to do. I think we don't have any actual people that are here for specifically at the request of the subcommittee members to speak on things. I guess if anything, before diving into the update of information requested by subcommittee members. So I am in the process of doing a synthesis document of all of the various items, the issues and possible solutions that have come up. I'm on phase 1. Phase 2 will happen after today, based upon the information presented at this meeting, the survey information, and incorporating some other things into that. So at the end of me, I'll check in with both you, Matt and Sarah, because the next step for the subcommittee is to do an update to the full committee next Thursday on that. So, and we can also talk offline on how to do this as well. Like if you wanted, for example, the matrix to be available or a summary or something of that nature on that. So besides the agenda on the subcommittee webpage, there is a document from the Workers' Compensation Division. You had asked the division to do a survey of other state laws on issues related to the subcommittee's charge. And so that information has been uploaded there. And I can, if people need it, I can do a direct transfer to that as well. And I believe Sally is going to do that presentation or walk you through the document.
Good morning, subcommittee co-chairs. We did a request to our colleagues. We are members of the IAIA-BC International Association of Industrial Accident Boards and Commissions. We did a survey of all other jurisdictions who are members there. We asked the questions that Teresa had checked in with you about to make sure we were asking the correct questions. We did get some responses back. We made some direct contacts with some of our contacts in those jurisdictions to ensure they did respond. We've compiled that list of responses. It is verbatim what folks responded back to us. So if there's any additional questions you'd like us to ask or clarifications on any of those responses, we can do that. What Teresa has uploaded are the first responses back. I think there are about 25, 26 responses there listed in that document. We have received a smattering of other late responses, and we will get those up, the most updated version to you. So. But we're happy to ask additional questions or clarifying questions because we did just in the chart, we put exactly verbatim as was the response.
Thank you. This is Matt. I reviewed it, but not super in depth. And I know one of the questions that has come up is around California. There was an assertion that they are one of the states. Are they involved in this, or are they not part of the?
They are an IAIBC member, so we can see if we have any more specific contact there and reach out to them and see if they will respond.
Thank you.
Also, Sally, is there any synthesis that you, after compiling it, that you see, that you have an opinion on, that, trends that, made sense to you?
We have not done that yet, Sarah. We were just trying to get it all put together and all together in the chart. So.
Thank you.
And I think it would, again, going back to the general synthesis document, pertinent information from this matrix will be incorporated into the overarching document as well. And so the other item of Rose requested was, I believe it was at the last subcommittee meeting, Dr. Ron Bowman had mentioned a study and in which in his looking at doing some research, we couldn't find that. So we'll keep looking, but there's nothing right now that was handed over to me. So.
And was that, I couldn't remember if it was a study. There was also a AMA position statement that they had referenced. And so I've gone through the ANA position statements and I couldn't find anything up at all.
I couldn't either. And in talking to Kara this morning, kind of getting ourselves prepped for this meeting, it might actually be from another another association. So maybe like the ACMED Association, which acronym doesn't come to me, but it might be. So we're going to look as our next step, go through some other associations to see if there's something there. And so I believe that's all we have from the division on that piece of things. I think the other question, I mean, is there anything else that has come to mind as far as follow-up information from what, so for example, like the MAC members or from the MCOs? We've only heard from 2 of the 4. I will try again with the other 2 MCOs for their feedback on the questions I sent out in September.
You know, if there's anyone present today from MCOs or that would like to talk, I mean, I think I see Ann Klein's here and anyone else.
Yeah.
You know, I think it's a great opportunity to get opinions while they're here, if we feel comfortable with that.
Yeah, I have no objection, and I don't have any anything else that I'm looking for you all to dig into. So yeah, that'd be fine.
Well, I can start, that's okay. Ann Klein with Majora's Health Systems, one of the managed care organizations, and happy to provide, you know, maybe some additional perspective regarding cadence of visits and continuity of care and access to care. One of the pieces that I know has been discussed is how easy it is for a worker to get in to be seen. And as a managed care organization, we're able to set specific expectations and guidelines for the providers that participate on our network. And one of those expectations that we have is that for any injured worker who has any form of work restrictions in place, that they be seen at least every 30 days. And there are some providers who may choose to do that a little bit more frequently. Depending on the nature of the injury, they may want to have those work restrictions a little bit more progressive in return to work. And the reason we do this is because we think it's important that there's regular assessments of those physical abilities and an opportunity to increase capacity and functional ability at work as part of their overall recovery process. And that return to work itself is by nature part of the recovery and rehabilitation, just like attending physical therapy visits can be. So that set of expectations is out there. And for the vast majority of cases, the medical providers and workers don't have an issue in maintaining that cadence of at least every 30 days. There is a subset where MCO intervention or support to help facilitate getting that cadence either established or reestablished does occur, but it is a small subset. I'm working right now to see if I can find a better way to quantify that rather than just it's a small subset. And if I'm able to pull some good data on that, I will certainly share with the committee. But it is a small subset. And I do think the other piece that's important to recognize is that there are a variety of reasons for why a worker may not be attending and meeting that expectation of every 30 days. One of the issues is certainly provider schedule and conflicts or limitations in being able to get that scheduled within that 30-day time frame. But we also have regularly also scenarios where the worker no-shows, calls to reschedule, which rescheduling pushes it outside of that 30-day time frame. They they're traveling for vacation or some other thing that puts them outside of being able to physically attend. And we also have times where the provider has indicated, please schedule follow up in 2 weeks, follow up in 30 days. And the worker just hasn't connected with the clinic to schedule that appointment. A lot of times when my provider relations department reaches out to remind the provider of the expectation to schedule at least every 30 days, that's one of the common responses that they get back from the clinic is, we tried, we reached out, we haven't heard back, or we haven't been able to connect. So there's a wide variety of reasons for when that happens. It is not frequent, or my provider relations team and staff would be overwhelmed if they were always having to call. And I think that there's opportunity there to discuss what are ways to help streamline and motivate for that small subset.
This is Matt. Is that in your is that 30 day, is that in the contract with the providers? Like, do you establish that in your agreement with them?
It is part of our agreement, yes.
Okay. Thank you. I don't have any further questions. I appreciate your time.
Thanks,
I
Ann.
don't either. Thank you, Ann.
Okay, so with that, we'll move to the next item on the agenda, which is public input and discussion on existing tools for encouraging medical treatment and the process to obtain wage replacement benefits when getting care. So I'm unaware of anyone who's that I know of that is going to speak specifically to this. So I open it up the floor to everybody here amongst the squares. Okay. Oh, David, did you want to speak? Okay.
Yes, I was trying to first raise my hand and then unmute, both of which are technologically challenging for this uncoordinated person.
It's Friday morning, it's been a long week.
So I would just say, from where we started is, in having raised this issue before to begin with, which is, it's just going back to the basics of what we're simply wanting to accomplish here is that for most injured workers, the system is working and they're connected to care. And there are a number of workers, hard to quantify, we admit, that sometimes get lost in the system. And the tools, I think we talked about, can be very punitive when you try from the insurance side to enforce. It's mostly kicking somebody out of the system. And our goal is never to kick somebody out of the system. It's to try to get them to the maximum recovery and back into the workforce to the highest possible level that can happen. So we've heard lots of the testimony and best practices and issues that are raised. I know the issue of access to care, and I think which is for comp, which is a system-wide issue for healthcare in general, and then there are specific issues for how its permutations impact comp, and I think that's a great issue for us all to tackle together too, to see if there's some things in the comp system that we can try to make it easier for attracting physicians and other healthcare professionals in the field too. And the issues relate, but there's still some separation. So, we've talked about timelines, how long, that was the legislation we had last time. And we said we weren't coming in with that idea. We wanted to talk about, are there other ways to, try to make sure that connections are made? I think there are a bunch of options to talk about. One is that, is there a 60-day or a 90-day or some period of time where there should be a connection or some requirement of checking in? That's an option. I think another option is just simply doing away with the open-ended time loss, saying that, a doctor should say, be it 30 days, 60 days, 90 days, 100 days, or 6 months because you need surgery, sometime that there is a known time that somebody has to be seen or be in contact with at a minimum their healthcare professionals, so that there is a connection and there is some date. So those are just a few thoughts I wanted to throw on the table as the committee will, talk about these issues some more. So thanks.
Hi, Kirsten.
Hi, everybody. Kirsten Adams with AGC. I wanted to follow up on David's comment. I think that seems like a solution that could deal with a lot of the issues that we've been talking about, especially, that the access to care and the issue that, it might be hard to put a specific date given that, we have issues with the number of doctors available for treatment and that sort of thing. But it also kind of still gives some timeline for employers to kind of have some, it kind of keeps things moving to a certain extent. So I think it could be a good in between where it gives the flexibility that the workers need in order to get the treatment that they need in the time frame that the doctor thinks is appropriate, but without having to, from the employer side, worry about like too prolonged a process, and kind of to the extent that might slow down the workers' care and that sort of thing. So, and I think one thing that could be a possibility if there are, concerns about it being too short, like, how long providers are actually giving, like our providers now is like, oh, well, I can give a shorter time frame that I've been giving or a longer time frame. Maybe we have MLAC give some sort of, best practices timeline, because I know that there's a variety of viewpoints on MLAC, and that could be an opportunity to get sort of like a professional, opinion of sort of what a best practices range might be, but not to say that is the defined range, but like, if you're treating for this kind of, this sort of incident or something like that, this might be the time frame you're looking at. And, not that has to be the gospel of what they do, but just sort of an idea of, of a range to look at. So I just wanted to add a +1 to David's comment.
Thanks. Good morning, Sherry.
Sorry, I'm a little bit off grid today. So if everything was a little fuzzy, I'm gonna literally off grid. I'm up at my cabin. So thank you subcommittee. And I love hearing what Anne said and Dave and Kirsten. For somebody that has literally been doing hands-on activities with injured workers since 1992, right after the reforms came in. Actually, my job evolved out of the reforms in trying to make those reforms work for Hoffman. We had a workforce prior to the Mahonia Hall reforms that would literally disappear and not come back. And in the construction industry, it was critical at that time, as it is now, to continue to build our workforce. And so I was able to, and I had to learn fast because I got to tell you, I didn't even know what a workers' comp claim was. Much like maybe some of the members of our committee, as you first come on, you don't even know how this process works. And so with the return to work, it was really important at that time to take advantage of the MCOs for Hoffman. And I kind of had to navigate through until I found the one that really worked for us and for our workforce, because it was really critical, again, to get people back to work as quickly as possible. And we do work in other states. So I have to say that Oregon was the model by which I was able to put together our return to work program throughout the United States. And one of the major factors that really was critical for us was the access to medical care. And the fact that the providers were, and at that time, occupational medicine was kind of fairly like newish. And what was this going to mean with providers? For providers, sports medicine was very popular, but occupational health wasn't. So it was critical that the providers were seeing those workers on a regular basis. We have high risk work activities, but we wanted to get people ingrained back into their work tasks at injury and make sure that they were going to be successful. And that program and the care that our providers throughout the United States have provided to our workers has been amazing. And Oregon has always been the state that I hold up to every other state, and I actively participate as much as I can in other states, and in fact sit on a similar committee to the MLAC in the state of Washington. And Washington is a great example, looking to Oregon to say, what is it that Oregon did so well with their reforms. And the number one activity was the return to work. And I actually, when Sally mentioned the IAIIBC, I actually spoke a few years ago at their conference about our return to work program in Oregon and the success that we had through the utilization of the MCOs and how critical that has been to, continuing to build our infrastructure for our workforce. It's been significant. And I think what it's done is it's allowed for when somebody gets hurt, they don't want to be hurt, but they want somebody to help guide them and make sure that that everything is going to be okay. So my job at Hoffman has always been to make sure that people are getting to their providers and that they're providing us with their information so that I can work with the teams to ensure that they're providing safe light duty. And if they need surgery, making sure that we're communicating with them so that we can get them back to work as soon as we can possibly get them back to work. And so I don't have these open-ended time loss issues. And I know that everybody in the work comp community always says, I'm looking through rosy-colored glasses. But those rosy-colored glasses started at a spot of not knowing anything about the workers' comp system. And this is all I know is state of Oregon. And it's what I tout to every other state that we go into business, including we're doing work in Israel right now. And I'm trying to use some of these fundamental ideas in the state of Israel. So what I want to tell you from a business perspective is I have seen it work when we make everything worker-centric. And what that means is making sure that our program is always about recovery and return to work. And if for those of you that know Victoria Kennedy from the state of Washington and Joel Sachs, the director of L&I, that is what they tout. And they do it because of what they saw us do in Oregon. So as we're looking at opportunities to collaborate, to make sure that the workers are not being forgotten and they aren't languishing out there for, indefinite periods of time. Ultimately, I know that every single injured worker wants to get back to work as quickly as possible. And so everything that we're doing should be with that ultimate goal in mind, including, I love Kirsten's idea of going to the MAC. That's something we often referred to when I was on the MLAC, is we would refer to the MAC when it came to medical. And we would put the onus on them to collaborate, just like your group does on the MLAC. So I thank you so much for letting me share that, because I am so proud of what we've done in the state of Oregon, and I continue to love the things that we do to enhance it. But I think we just want to make sure that we're always being worker-centric, and recovery and healing and return to work are the optimal goals for everybody. Thank you.
Thanks, Sherry.
Sherry, I have a question.
Sure.
Thank you for your input. I appreciate that from your perspective on your model. And you spoke about you don't have any open-ended time loss out there. Can you speak more to that and like how that works and why you don't have any open-ended time loss?
Sure. And I think this has a lot to do specifically in Oregon and in other states, is communicating so if somebody does go out, typically, number one, it is the only time anybody goes out on time loss from the very get-go is somebody that is bedridden and admitted to the hospital. We will provide light duty of any type. I mean, we've learned over the years that the best person to help us with what the light duty would be for the restrictions is actually the injured worker. So we are communicating effectively with the provider and the worker right from the get-go. These are the ideas, as somebody is going to offsite, what are things that you can do? Make sure you're communicating with the provider for that initial injury appointment. And then if they do have surgery, we are making sure that the provider has that information as to what transitional work we will have available, and would love to have the opportunity as soon as they feel worker is capable to be able to return to work, to be able to do that. And so we are communicating effectively with the injured worker, and we're communicating effectively with the provider. And I think there's some companies that may limit their transitional work time. Hoffman's goal is ultimately to get workers, and where our subdivision that has the craft workers especially, they have union agreements. And so we want to make sure that we're sticking within the guidelines of the union agreements, but we want to make sure that those workers, when they get done with, let's say they get done with Research Stadium at OSU, that they are able to go to work for any employer. They can get dispatched out of the hall tomorrow. And so our goal is always to make sure we're working through from, and I don't know that I want to use this, maybe this isn't appropriate. The cradle to grave is my term. At the beginning of the claim to the end of the claim is making sure that we're all effectively communicating, and takes a village to make sure that the worker has the most successful outcome. And Sarah, something else to note is that Hoffman, on many of our large projects, anything that's over 90 million, and I've said this before, we will do what's called an owner control or contractor controlled insurance program, where we aren't just insuring Hoffman's employees, we're also insuring our subcontractors. So this model has been very effective in working with, hundreds of our subcontractors who have injuries too. We educate them on the best practices to ensure that we're all on the same page and all of our workers are being treated in the exact same way on the job site, and are with that ultimate goal of everybody gets back to work and is back at full duty before the job ends, if at all possible. I hope that answered your question.
It does. Thank you. I appreciate hearing the best practice from the business perspective.
This is Matt, and I actually have a question for you, Sherry. You had spoken about like light duty, so I was going to ask about that, like having kind of these. I believe the term that I've heard through this committee, the subcommittee, is the bona fide job offer. So I'm curious, kind of your process of getting folks back to work through light duty. And then also some of the barriers that we've heard around folks who are on light duty is then the challenges of the release to go and maybe they have a physical therapy appointment. And you would actually be perfect for this because your job sites are not just at one place. And so if they have a physical therapy appointment, do they lose a whole day of work? And how does that work with PTO? And so I'm just curious how you all manage that, the light duty or bona fide job offer function, as well as then I guess, incentivizing or supporting workers to maintain that connection while they're also operating in that light duty framework?
Sure, great questions. And I've actually had some significant experience in this area, specific to the time away from work. So we do what's called a transitional work agreement for every worker that is placed on restrictions. It lists out what the restrictions are, and then it lists out what the new assignment that has been, collaborated between the worker and the supervisor. And then we have the doctor sign it. So we are taking those documents with us to the first time the worker goes to the clinic to make sure they don't miss a beat, because if they miss a day or two of work, that can be detrimental to them. And we want to make sure that we don't miss any time. So we work with the providers, the worker and the provider at the clinic to make sure we get that document signed. Then the follow-up visits, we ask the worker to try to make them towards the end of the day. The first day when they get injured, that day is paid in full. And so maybe I should preface this, that up until 2009, from 1992 until 2009, we were paying workers to attend their doctor visits. It was horribly abused because nobody could track it. And we don't have like a punch card system for workers on the construction sites. And in fact, through our union agreements, our workers get paid when they're physically working. And when you think about it, when a worker goes off site, there's also, or when they're away from work, at work, you have their hourly rate plus their fringes plus their whole package. So the goal is to make sure that workers are trying to make those appointments first thing in the morning or at the end of the day so that we can get as much of their 8-hour day in as possible. And then with physical therapy, physical therapy can run into the evening, and it can also, you can get them on weekends. And so there's a lot of opportunities there, but I have to say, I was so supportive of making sure that people would get paid while they were away for their appointments. And Matt, tragically, it was abused. It was abused. We had people going to the bars and not coming back to work. And it wasn't everybody, but it was enough to where it was not fair to everybody else that was doing the right thing. So we stepped back on that in 2009. So that was, we had a couple decades of doing that, and it really was not successful for us. However, I did come across, and I thought I would share it with this group. One of our union agreements that we have in Arizona actually requires that the worker get reimbursed for 2 hours, by the employer. So me as the employer, Hoffman, if I have a worker get injured, and Carpenter's Hall down there, if they get injured, we have to reimburse them the day of the injury, which, just like we do now, and then up to 2 hours for the first 3 follow-up visits. Okay, so and that 2 hours is similar to what we have at Hoffman for our salary employees, but there's no other union agreement that has that. So it's actually written into our union agreement. So we have to follow that. And we're trying, it's kind of an interesting dynamic that we're learning how to track, because we failed so miserably, in the 90s and up until 2009. So we're kind of, how do you track this to make sure that, number one, that if the worker's leaving the site for a doctor's appointment, that we actually know they're leaving. So I don't have anything to add to that, how that's working, but just that it is something we're working through. Was that helpful?
Yes, thank you.
Okay.
Okay. With that, is there anybody else that wants to speak on this issue before we move to subcommittee discussion?
I'm sorry, I don't seem to be able to find my.
Oh, you're fine, Giovanna. No worries. I'm sorry I didn't see you.
Raise the hand button. I was looking for it, but
That's okay.
Just chime in. So, I do appreciate hearing from everyone, and I missed the last meeting with the doctors, but I was able to listen to it this morning, and I felt like there was some really helpful information in there about what it's really like here on the ground for the doctors to be working and trying to get these patients through the system. So what I'm hearing from Ms. Sundstrom and Hoffman is that there's no problem with the way the rules and the law is written currently, as long as the employer is engaged with the claim processing. And I think that's something we haven't talked about a lot, is education to employers and working with the employers to help them understand how they can use the existing tools that they already have to effectuate positive engagement with care and positive return to work. It's working at Hoffman. Unfortunately, most employers, a lot of employers that I see, don't have that sort of structure or education or apparently, desire to do that. What I see a lot, and I hear this from probably 3 to 5 of my workers every single week, is how do I get to my medical appointments on light duty? And what the response usually is, my employer said, I need to take the whole day off. I can't come in if I have an appointment. We can't have every single worker who's injured schedule an appointment for the first appointment of the day or the last appointment of the day or on weekends. Heard from all the doctors about the shortage of employees, shortage of physical therapy. And so it just doesn't work. Even at Hoffman, they expect you to go first thing in the morning or last thing. And that's just not possible for everyone to be seen like that. I think what we heard from Dr. Lawler is that the doctors are trying, they are trying to get people in, they are trying to get people to ancillary services, and it's hard out there. We all know that just from our own experience. So I would say, let's not do something that's going to cause more stress to the workers and to the providers and potentially push more of these providers out of the system. I do appreciate that the folks who are on MAC and on the MCO, they are a lot more aware of the rules, and they have different rules than what the law and the rules require. We don't want to push every other provider out of the system because it's too complicated, because they're going to have more paperwork, more stuff to do. So I think what I've really seen here is, there's been just no showing in all of this discussion that this is an actual problem that needs to be resolved by having an arbitrary cutoff of time loss benefits. No other state, I looked at the stuff on the states, no other state has an arbitrary cutoff. I think one of them just, when it's open-ended, they send it back to the provider for more information. Nothing about penalties to workers, which we've heard don't work. But, we don't even know from all of our discussion here, how many workers are actually given work releases that are longer than 30 days or longer than 45 or longer than 60. We don't know how many workers have open-ended releases. We heard from Dr. Lawler that her colleague puts out 2 months, but sees them quicker, just does that as a safeguard. So just because it's long doesn't mean that they're not going to be seen timely, that they're not engaged with care. We just don't have that information. We don't know also if workers with open-ended restrictions are the workers who are not being engaged with care. We heard a lot about missed appointments and follow-up calls that the doctors make. Dr. Lawler was surprised that the insurers didn't use all of the tools that they have, especially the scheduling the appointments themselves, and that falls on the doctor's office, who is already short-staffed. So it seems like if the insurers aren't willing to use the rules that they already have, the existing tools, and we don't have any real data on a connection between an open-ended work release not being seen, not being engaged with care, it doesn't seem like it is a time to make changes to the rules that already exist when there are plenty of them. And I would just repeat that if we are going to talk about some sort of change, there is, penalizing the worker again and again, we've discussed that is not helpful, not useful, especially when we talk about low-income workers, workers who have language barriers, and small mom and pop employers who are maybe doing their best, but don't know how to run a claim properly. They are the ones that need the education. We send a ton of stuff to the workers, but it's more of a question of all of the parties here using the tools that we already have to make sure that they stay engaged. So thank you.
Thanks, Giovanna. I have Kirsten first and then followed by David.
I just wanted to respond to one thing that Giovanna had said about Sherry's example about their ability to follow a claim and that sort of thing. And I just wanted to point out that, excuse me, the size of Hoffman allows for that sort of, allows for somebody like Sherry to do that. If you're looking at a smaller, a smaller company where they don't have a person that's dedicated. I mean, I wish everyone could have a Sherry on their staff to assist with the processes and that sort of thing. But in reality, if you're talking about a company that has, it's like a small, fewer than 10 employee company where they have one person doing all the administrative everything in the back, it's just not feasible to have that level. So I think that it's not for lack of wanting from the employer's perspective. It's just a lack of ability in a smaller company to have somebody that is able to dig in at the level that Sherry is. And one other thing, Giovanna mentioned several times about penalizing workers, and I don't think that's anybody's intention here. I don't think that any of us have the intention of penalizing workers if they, have difficulty getting into their doctor. I just wanted to correct. I haven't heard that from anyone, and so I just wanted to correct that. I don't think that that's anyone's intention in this group. So. And I think David probably has some other things to add on to that.
I did have a follow-up. This is Matt regarding that. So it sounds like the Sherry's company is enormous and is operating across states and even countries. So I think there might be a scale. So I'm curious about that. If we're looking at the capabilities of that company, I'm just wondering, when you said, well, if there's a company with 10 employees, it's unlikely that they have this, that all 10 are out at the same time and they're trying to track that. So is there any, maybe folks know, is there kind of any equation, like you can kind of expect that you're going to have X percentage of your employees out on work comp based on this industry? Do folks explore that, or so that we would be able to see that a small business may have that capability through their human resources, and they could do some predictive analytics and kind of know how many people they would be having out? Do you know of any of that?
So I don't know in particular, but I do know that, to your point of scaling, I think as the companies get larger, you tend to have, a broader, at least I can speak from the construction industry, a broader safety team or a broad, you have sort of more in that space that can handle this. But like I said, and I don't know exactly where that, and it might just be based on the company and what exactly it is that they're engaged in. So I don't know that there's like a sweet spot where it starts to switch over to the ability to have somebody more along the lines of Sherry, but it's probably a scale, but others, I see several other hands, so I'm gonna punt it to who might know the answer.
Yeah, I was gonna say,
Thank
I
you.
saw that Caitlin raised her hand and I think.
I saw that.
Yeah, I was gonna say Caitlin probably can give a response.
Hi, yeah, this is Caitlin Brightball with the Small Business Ombudsman's Office. I raised my hand specifically to kind of reiterate what Kirsten was saying about the size of the companies and how that can really be an obstacle when it comes to making sure that these claims are processed in a timely manner. Not everybody has the capability or the knowledge base or any of that to be able to make sure that their workers are being processed through the claim process appropriately. I would say anecdotally, just based off of the people we work with in general, the desire to help the worker is there, but the knowledge base is very little. And making sure that, like you said, the reaching out and having education, that's great and everything, but we can only like do so much as far as like making employers come to us or, calling us or going out to certain places. We can have the education available, but that doesn't necessarily mean that everybody will even know about it or partake. So, and then to add to just kind of what I've noticed as far as these open-ended time loss, usually when an employer calls us in regards to a claim, sometimes it's stalled for whatever reason. And it's not necessarily the fact that they want the claim to close, but there's just no knowledge of when it's going to close or what's happening or any of that stuff. And so it ends up being kind of this open-ended problem that they don't know what to do with. And it ends up creating an instance where their experience modifier is going up because the cost of the claim is going up. And, just to reiterate, most of these businesses that are calling us on a daily basis are under 50 employees and definitely don't have somebody who is able to kind of walk through this process with the claimant and the insurer, and they're just kind of doing their best. And then they don't realize why their claims costs are kind of out of control and, all of that. So I just kind of wanted to reiterate how the size of the company can really affect how claims are kind of processed and the timeliness in which things are closed and how that can affect small businesses in general with how much their workers' comp ends up being and how it can be kind of a detriment for small businesses for their claims costs to just keep climbing. And when there's open-ended time loss and there's no kind of end in sight, that those claim cost dollars just kind of keep adding up and adding up and adding up. So I kind of just wanted to reiterate on that specifically.
Thanks, Caitlin. Sherry, I saw your hand raised. I'm guessing you're going to add to this piece of the conversation.
Yeah, so I want to make sure everybody understands why I gave you that overly bit about Hoffman is I have been able to utilize, the tools. I mean, but that was like everybody is saying, it's one person. And if there was a situation with one of our subs, and I don't always know what's going on with our subs if I'm not personally involved in those claims, where somebody wasn't able to come back to work because of these open-ended time loss, that would be, that defeats, so much of what we're trying to do in the industry. But, I'm glad that you picked up on the fact that it takes a village to take care of this. So I think it's so critical, as I first said, that we are worker-centric recovery and returning to work. And that should be the ultimate goal from day one for everybody engaged. And they can't do it if, number one, they don't understand how the process works. And if somebody is out there, needlessly out there. And I don't know that any worker I've never come across a worker who wants to stay at home indefinitely. you know, and that's not to say that we haven't had problem claims, but that's a whole different set of baggage as opposed to somebody having an injury and just hanging out there with no hope of coming back to work. So I'm going to say, I think the goal is always, the best goal is to get people back to work as quickly as possible. And to ensure they're doing that is by making sure that they're getting the care they need, which is, you know, what we've been so successful at doing and being able to utilize those tools. But I think everybody's right. It does take a lot of work to do that. And most small employers don't understand that. And the education until they have an injury, they don't even know what a work comp claim is. I started this all off saying I didn't even know what a work comp claim was in 1992. And I've been with the company for 7 years. So it was, I hope that's helpful. I don't want somebody to think that I thought that open-ended time loss is not a big deal. It would be a huge deal for us, but for the fact we're able to utilize the tools. And I'd like to point out too, just for everybody, I'm very well aware that most of our subcontractors, their carriers don't even have contracts with MCOs. So they don't even have the benefit of like Majoris or Providence's MCO that can help with their own guidelines. And so those people are, you know, they get a double whammy. They don't have an employer and they're not part of an MCO. So keep that in mind as well as when you're talking about this.
Thanks, Sherry. David?
First, I don't know if there's anybody who's on the list of speakers who hasn't spoken. I mean, I've already spoken.
I do not have a list actually, so
Oh, okay.
I'm just going by who's raised their hands and turned on their cameras.
Okay. Okay. So just to respond a little bit to what Giovanna said, and you know, I think that there are a whole bunch of elements in what she said that are issues that we need to take up and we would support, and some of them are on your work plan. Intimidation, retaliation, access to the system, you know, I would characterize as for low power workers, language barriers, what we can do. I think that those are all issues that I would hope we can work on together, and I would hope that MLAC can put together, they have the items in a work plan, but some structure for trying to get us together to address those, because I think there are a lot of areas that we all agree and we should really move forward on, and there's probably some low-hanging fruit to try to address some of those issues. Second, just SAFE has 55,000 policyholders, of whom 75% have fewer than 10 workers. And most of those employers have never had a claim. So when they do have a claim, it's often, you know, no matter how much information you put out and make available on the website, how many, you know, workshops that you invite them to, or for us, we offer, you know, consultation from our safety staff, of which we did, you know, I think over 9,000 consultations with businesses last year. You know, and we offer those services to businesses no matter what size or how much in premium they've paid. You know, that it's still a new world for them. So we try to work with them to make it easier, you know, to go through the system. Often they don't have an HR, it's just the proprietor who's doing all the work. Sometimes they've contracted out their HR and payroll, so they're even a step removed. So those businesses often may not have light duty, and we try to work with them on that also. I think that's a whole other, you know, discussion too. But two other points. Well, one point, and then getting to I think where we are on this is that you know, when we addressed the issue of time loss in the legislation last session, where we all came together and supported, after the work of MLAC, you know, the passage of major legislation brought by the trial lawyers, a lot of the items in there didn't have data to support them. They had anecdotal stories. And we went along with the anecdotal stories without demanding that there be data, because on a bunch of the issues there wasn't data. And, I'm just surprised that we don't get the same sort of respect here on this issue. And I think the ask isn't all that much. They ask, one thing, we'd love, we proposed what our preferred alternative was in the session, is some regular renewals of time loss. And, that clearly met with a thud for some of the reasons you heard. And we still think that there are ways of making that workable, but we, appreciate our partners in the system and think that, just saying that there has to be some point where somebody has to come back and get their time loss renewed, meaning they have to be in contact with a physician, be it in a month, 2 months, 3 months, 4 months, 5, whatever it is, but there needs to be a date where that needs to be done again. We've heard how onerous it is, and we can, I won't comment on, but to do it every 30 days or every whatever. But it just doesn't seem too much to ask where a employer in the system is paying somebody's replacement wages so they can get better, that they check in, have some date when they need to get that renewed and checking in with their physician. So that doesn't seem to me to be an onerous ask. It doesn't seem to me that it will cause hardship in the system, and it can have the benefit for the very limited number of workers that that's not working for. And yes, there are tools, again, that insurers have, except that, they lead to a path of kicking somebody out of the system. And that, again, isn't what our goal is. So you've heard from me enough, I think, from that. And so I'll stop talking at that point. Thank you for listening.
Thanks, David. Keith, good morning. Thank you for your patience.
Oh, no problem. No problem. Happy to wait my turn. So I'm hearing some kind of conflicting things. I'm hearing that one of the major goals is to get workers back to work, but I'm also hearing that a lot of employers, even if the work restrictions are or aren't open-ended, just don't have the bandwidth or wherewithal to do that. I'm hearing that a lot of these are small employers, yet I know that those small employers have insurers to assist them with the various intricacies of getting a doctor to sign off on a modified job offer and the like. So we've got workers that have partial work restrictions, and we've got workers that have total work restrictions. We've got workers that are doing what their doctor has asked them, and we have a subset of workers who are not doing what their doctor has asked them, who are actively disengaging in their treatment, trying to dodge the doctor and stay on work restrictions. And my understanding is that's really the group of workers, or at least makes sense that that would be the group of workers that we're really concerned about. The ones that aren't doing what their doctor's asking to get better, aren't checking in, and are in a position where the employer can't say, okay, you have work restrictions, I've got some work for you, let's get this going. Great what Hoffman does, and I understand they've got more bandwidth than most, but I mean, they're using the tools that exist, and they're able to make it worker-centric in terms of getting a worker back to work, keeping the doctor engaged in that discussion and the like, and that's processing the claim. That's doing what the law currently requires and using the tools that the law currently requires to maximum effect. The only way that cutting time loss off on a specific date is worker-centric is it dumps all the obligation on the worker, and it dumps all that obligation on every single worker on wage loss in the state, regardless of their circumstances. I think that is very much too much to ask and too onerous for the small subset of Dr. Dodgers that we really need to get engaged. And a lot of those people can be dealt with the existing tools. I mean, I keep hearing that these existing tools are too punitive, but cutting the worker and their family off a time loss because their doctor won't cooperate with the date the insurer set, somehow that's not a penalty. Nobody's saying that's a penalty. I'm saying that's a penalty. I don't like it. It's not something that I'll support. It's not something I'll ever support. The insurers need to find the bandwidth to use the tools that exist and help their employers engage with the doctors and the worker to get people back to work, if that's really the problem that we've got here. The other workers, the vast majority of them are engaged in the sense that they're doing what their doctor has asked them to do, and they should not be swept up in this discussion. Thank you.
Thanks, Keith.
This is Matt. I do have a question for David. In looking over some of the other states' processes, and then I have a question regarding, I think it's been referred to as the bug letter. And so that is something that could be used to, and like there's no conditions if you send a letter that you have to suspend or terminate the worker's income. But is that a tool that could be, is it used now to facilitate that conversation, to identify gaps and maybe why the continuation of care has been interrupted? And I'm just curious how that works. It seems like when we discuss some of this, I keep coming back to looking at the other states that have what looks similar to that process. And when I hear kind of some of the problems you're articulating, it sounds like that would be the solution. So I'm just curious on that one, if that would, why that isn't helping with the engagement currently.
Thank you, Matt. I'd like to have Dan Schmeling, who's our claims quality assurance manager and had been a claims adjuster and manager, respond to that. He will do a much better job than I will, if that's okay.
Hey, Matt, this is Dan. The bug letter, I don't want to say is a threat. It's a tool that's used to close the claim, not just to stop time loss, but to stop time loss and close the claim. And so if a worker is not actively engaged and has not been seeking medical treatment consistently, and they don't have a follow-up appointment, we can send the bug letter out if there's been a gap of more than 30 days, or if it's a longer time frame as outlined by their attending physician. And the bug letter basically says, and I'm paraphrasing here, have you given up on your treatment? If so, we're going to close your claim, which means we're going to end time loss. We're going to close your claim. And if you disagree with that, please let us know and schedule an appointment to get back into your doctor. If not, your claim's closed. So if the worker responds with, yes, I plan on seeking care, we can't proceed with closing the claim because they've responded within the time frame allowed. They don't have to schedule an appointment. They don't have to have an appointment with the doctor. They just have to respond with, I plan on seeking follow-up care, and we can't close the claim. Now we can wait another 30 days and this worker still hasn't sought treatment and still hasn't scheduled an exam. And then we can send out another bug letter saying, if you've given up on care, you haven't sought treatment now for over 3 months. And if the worker responds with, no, I plan on seeking care, we can't move forward with closing the claim. And so that isn't a tool we like to use, because the intent is we want the worker to be seeking medical treatment if they really need medical treatment. If we're going to close the claim, we want a good assessment of what their permanent impairment is, so that if the worker challenges it and requests recon, that the recon affirms what we did because we had good medical evidence when we closed the claim. And so is it a tool we can use? Yeah, it's basically just kicking the problem down the road and making threats to the worker. So I guess, that's kind of my comment on the use of a bug letter.
Thank you for that. And just to be clear, so if you send the bug letter, it does engage the conversation, or I mean, you're not required to close the claim, but it could be the initiation of
No,
that.
we're supposed to close the claim. If the worker doesn't respond in the time frame or responds with, I'm not going to seek treatment, we're supposed to close the claim.
Is a requirement that you would have to close it then?
I believe the rules say we must. So yeah, I mean, I guess asking this question, should we be making threats and not following through on the threats?
No, well, I guess that's the thing, is I keep hearing that we aren't talking about being punitive, and that does sound
it's pretty punitive.
Right. And so but it also sounds like you know, some of the other suggestions are punitive. So I'm trying to understand all of your tools available. I appreciate
Yeah,
that. Thank you.
I don't view the bug letter as a tool used to promote the worker to seek treatment and to get their time loss authorized. I believe the intent is when the worker is given up care and isn't treating anymore, to say, hey, it looks like it's time to close your claim. Is it time to close your claim? If so, please go back into the doctor, have that closing exam so that we can close the claim properly based on the attending physician's medical report. Otherwise, we will go ahead and close the claim. I don't view it as a tool to manage time loss authorizations. That's where we'll reach out to the AP and say, can you continue to authorize time loss? Does the worker have a current medical appointment? You know, when are they supposed to return? Versus saying, we're just going to close your claim if you don't respond. So,
Oh, okay. So you do have that ability then to, you will just reach out to the physician and follow up that way to get some of that.
yes, we can do that. And that maybe gets into the hassle factor of, you know, going back to the doctor repeatedly with, you know, the worker hasn't been seen. Can you give us an update? Oh, we're going to see him in 2 weeks. Oh, okay. If we knew that, maybe we would have waited 2 weeks for the chart note. But quite often we don't know that information. So without reaching out to the doctor's office and taking up their time and resources, we don't know that information.
Dan, this is Sarah. I have a question along those lines as well. If I'm assuming these instances are with open-ended time loss, because if time loss had a defined date, you would know when they were going to be checking in. Is that correct, or am I missing that?
Yeah, those are I don't want to say the easy claims. Those are the claims where when we know when the follow-up appointment is, we don't have to reach out to the attending physician and say, can you please give us an update on the worker's work restrictions, because we know that they're going to be seen in a week or two. And we can work with the employer and say, hey, we know that the worker is going to be seen in 2 weeks. So we can probably get updated work restrictions at that time. And we might even write to the doctor and say, when you see the worker in 2 weeks, can you please address their work restrictions, because the employer has this potential for modified work. And we would like to know if they can return to that modified work. But when we don't have that information, that's when we go out on these expeditions of sending letters to the doctor or phone calls or faxes saying, we don't know when the appointment is, so can you give us an update?
Hi, Giovanna.
Thank you. I mean, I just have to say that I guess I've been reading bug letters wrong my entire career, because I disagree with Mr. Schmeling on what they require and how they are used. It is my understanding, and the bug letter says it right on there. Have you completed treatment? We can close. Or tell us the date and the name of the doctor of your next appointment. I have never filled one of those out by going back and saying, I'm the worker's being seen. You know, it requires the name of a doctor and an appointment to be set, not within those 14 days, but the appointment to be set. And I think if the workers are returning these without lawyers saying, I intend to seek treatment, that should trigger claim processing with the adjuster and with the employer. Call the worker, call the doctor, you know, are you being seen? Well, let me set that appointment for you. What are the problems here? That's still engagement with care. That's still the worker letting the adjuster know that they do want to seek care. And then the adjuster, as the one who's supposed to be processing the claim, should be the one to reach out and figure out what the impediments are or help them schedule. I see insurers use the bug letter to cut off time loss all the time. I have had adjusters send a bug letter on day 31, every single day 31 in a claim, you know, every single month. So I think insurers are using these to cut off time loss. They are effective in getting the worker to engage. I think they're one of the most effective tools, but they are only one tool. Even as Mr. Schmeling said, if they return it and say they're being seen, but they don't see a follow-up, that gets the adjuster to schedule the appointment for the worker. That's another tool. That one thing it's not mentioned again is the bona fide job offers. why isn't that a kick to get the bona fide job offer out to the worker? All of these things are things that can help them engage. And I just read the bug letter in a completely different way than apparently the insurance industry does.
Well, to that point, I was speaking for SAFE. I can't speak for other insurers. And the question was, don't you use the bug letter, or can't you use the bug letter to stop time loss and close the claim? And so my response was, as far as closing the claim, if the worker responds that, yes, I do plan on seeking treatment, or I am seeking treatment, we can't close the claim in that situation. Can we just arbitrarily stop time loss? I would still say no.
Yes, of course you can. If you do not have an authorization from a doctor for time loss, then of course you can cut off time loss.
So if it's an
You can send the
open-ended
worker out
time
to an
loss
appointment. Of
authorization,
course, you can send a bona fide job offer.
I'm going to interrupt real quick, Mr. Schmeling. My question was more, isn't that letter used, because our discussion is around maintaining connection with care and engagement. And so I was more framing it to kind of get an understanding if that is a tool that facilitates that engagement, not necessarily, because I don't believe our intent is looking at how we cut workers off in the subcommittee. That's not our charge. So I was more looking at the tools available for engagement of care. I understand especially hearing from Ms. Sandstrom about how their active participation in getting workers back to light duty. And so I was just trying to, I understand that we have that bona fide job offer available in our statutes, but I was looking at the bug letter more of that, getting that conversation going and that engagement back into the care if it's somebody who is slipping, not necessarily of, don't you already have the ability to cut somebody off? So I just wanted to clarify that.
okay. So to that point, and to Giovanna's point, yes, we can use that as a tool, and we could send it out every 30 days if we wanted to with, are you going to seek treatment? Are you going to seek treatment, or should we close your claim? So if you wanted to look at it from that standpoint of, yes, it is, in my opinion, a heavy-handed threat that we can use on the worker to call it gain compliance. I guess from my perspective, we expect our adjusters to guide the worker through the system instead of making threats repeatedly with, if you don't seek treatment, we're going to close your claim and cut off your time loss benefits. And that's how I view the bug letter. There's times when it's effective, and there's times when it can be viewed, I think, as a heavy-handed threat. And wouldn't we rather have that predictability of knowing when the worker is going to seek treatment next, so we know when to expect an updated work restrictions, or we know when to expect the updated time loss authorizations? You know, add predictability to the system.
Thank you. I have no more questions. I don't know if Giovanna, if your hand is still up.
Oh, sorry. I will lower it there. Thank you. And I would just say that, you know, predictability is great, but this is not a one-size-fits-all system. Obviously, there are times when the doctor chooses not to set a specific date. Dr. Lawler talked about her colleagues, you know, saying 2 months, but I'm going to get you in sooner, you know, because doctors can't always set the appointments right then. Any rule that would have a cutoff date that was a one-size-fits-all for everyone would be punitive for everyone, would be heavy-handed for everyone. And it would be a worse sort of heavy-handed because it's a rule that we all know exists, but workers probably don't. They're individual people. Employers and their teeny little offices, they're individual people. So a bug letter is a specific thing from an adjuster on a specific claim. Worker, you haven't done this, you need to do it, go do it, or we'll close your claim, rather than imposing some broad rule that doesn't go in line with workers who are all following their restrictions. I just want to say one thing, since Mr. Berenberg brought it up, about the antidotes. You know, when we came forward, what was happening, we were talking about things that are happening with our workers every day of the week. I can tell you, you know, I just said 3 to 5 times a week, I get a call about being able to go to your medical appointments, about, you know, 5 to 10 times a month, I get clients with bona fide job offers who ask me about how they can get to their appointments if the offer. So those are actual hard numbers. Mr. Berenberg said that this open-ended thing is affecting a very small, limited number of workers. So that's what we have to go on. Let's not change all the rules for what the insurance company is saying is insurance industry is saying is a very limited number of workers who are not following the rules. And the tools are there for them. Thank you.
I have a comment that I heard Dr. Lawler say that they used a date for time loss, not just open-ended, intending to get someone in sooner. So I did hear it was not an open-ended time loss. So I think that is what we're talking about here. And I guess anybody, I would ask, how is an open-ended time loss beneficial to a worker if we're worker-centric, getting them back to work, getting them returned to work, getting them on light duty? What does that achieve?
Good morning, Paloma. Oh, your hand's down. Okay, never mind.
I don't have an answer to Sarah's question.
Okay, that's what I figured. I figured your hand was raised. Your hand was raised before Sarah's comments.
No, that's okay. I mean, I think it's just, to put that out there. If open-ended time loss doesn't achieve any of those things, how is that beneficial? So maybe it's something we can all think about. And I'd love to hear from Paloma.
Yeah, well, I can comment on that just a little bit. And it's again, that we don't have a one-size-fits-all system. I think that it's actually quite rare that we see straight open-ended releases, or we see a worker who goes in to their appointment with their attending physician and does not get another appointment set at that same time. So this isn't a big problem. It doesn't happen that often, which is why it's not a problem that needs a solution. But what I see when there's open-ended time loss authorizations that are working for the system would be like what Lon mentioned at the last meeting. If you're post-surgical, if you're maybe thinking about surgery, want to do a course of physical therapy or a course of work hardening, or go get that MRI and then come back and we'll talk about your options, and those things take time. So having it open-ended in that sense, tied to a future event that doesn't have a specific date, that makes perfect sense. And that's how the medical field, medical offices work.
But Dr. Lawler did not have open-ended time loss, correct?
I'm sorry, he was able to get back in with his surgeon, but there's nothing wrong with, we didn't hear that there's something wrong with a surgeon not seeing the worker every 30 days.
I didn't say 30 days, just open-ended, correct?
What Lon discussed was that there was a difficulty in getting into physical therapy, and that sometimes he'd see his doctor at the schedule that his doctor chose, and that sometimes his doctor would have nothing to say to him because he hadn't gotten the treatment that was recommended because of the time it takes. So that doctor chose to see the worker every 30 days. That's what, that was my understanding from Lon, or whatever schedule they were on. If a doctor instead chose that I don't need to see you back until you complete those things, right now our system is okay with that. And it's Otla's position and my position that it should remain that way. We should not impose some arbitrary duty when this is working for the doctors, and there's sometimes very good reasons why they are not seeing the worker until something has occurred.
I also heard Max say that they were very surprised about open-ended time loss, and they didn't see that was a best practice as well.
I would assert that then when we were able to discuss with them, their responses were incongruent with their surprise, because I forget the chair's name, the orthopedic surgeon had mentioned, it seemed actually what the crux of the matter came down with was insurance approval for things like physical therapy. And they both acknowledged that that was a significant barrier and created a situation where having the open-ended potential was beneficial because it didn't burden their offices, which they all acknowledged were overburdened. So I think we could review the minutes and kind of look at that. I mean, there was once when Max seemed surprised about it, but then all of the physicians who were directly questioned, even when we look at the MAC minutes, acknowledge that there seems to be some case-by-case basis necessary.
Right. No, I agree with you, Matt, that they were definitely talking about a 60-day or a longer period that so they could have that window to be seen, but I didn't hear any, and we could review that for sure, but I didn't hear anything about straight open-ended being beneficial to the worker. Did you hear that, Matt, or did I miss that?
No, what I heard was that there was a lot of, I didn't hear them say that they would need a requirement as well. So yeah, we should review with that.
Okay, Anne's hand was raised, so I'll call on her, then Paloma.
I wanted to comment on, I think that's a fair point, that occasionally there are barriers to an attending physician makes a referral for a particular type of treatment, and sometimes that gets stuck. But I would counter that rather than saying you should just hang out for however long it takes to get you in, that regular check-ins with the attending physician also allows the attending physician to identify that there's a stick in the process and help advocate for the injured worker and identify either alternatives in the interim or help them identify what do we need to do to help grease the wheels. But leaving them just out there waiting for that PT visit to first occur leaves the worker without the support of, let me advocate for helping you get into that care that I think is important.
Thanks, Anne. I do have a question regarding that. And this would be, so one of our members, a nurse, an O&A member, their visit with an orthopedic surgeon who is not their attending, and this is after they have been through physical therapy, arthroscopic procedures, and now, this is probably a year. Then the orthopedic surgeon said, you will need a more invasive procedure, so let's get that scheduled. And it was over 60 days. It was pushing, I think, like 90 days by the time they get the procedure lined up, and they're not improving. And so their attending physician doesn't, I guess my question would be then, considering the burden on our healthcare system, what value is having this person who is having to wait for surgery, and because of how far these things are booked out, what value is then going to see the attending? They have a specialist, the orthopedic surgeon. The attending knows they were sent and referred to the orthopedist who's going to conduct surgery. And so this would then be using up the resources of that attending physician's office to go in and say, yep, still got that surgery scheduled in late October, and nothing, So I am asking from your standpoint of operating the MCO, do you do that? Is that kind of the standard procedure? Is, okay, we've got you scheduled, it's going to take 3 months, but we want to make sure, because we have this agreement with our attendings in the contract, that you're going to pop in every 30 days and see them. Is that how it operates?
We do continue to have an expectation of that frequency of check-ins. It does allow them to, generally, when you're waiting for a surgery that's pending, of saying, okay, this is the next step, there's still conservative care. Oftentimes things that the attending physician or the surgeon wants to occur to help ensure that when they do get scheduled for that surgery, that they're in a good condition to support best outcomes possible. And it provides that opportunity to check in with the worker and ensure that we're on track, we're meeting conservative care approaches in the interim. You really still, even if you're waiting for surgery, don't want somebody truly just sitting and waiting. You want some level of engagement on the conservative care until that point.
Thank you.
Now we'll hear from Paloma and then Giovanna.
Thanks, Teresa. Paloma Sparks, Oregon Business and Industry. Just a couple things, especially since we've had a lot of these conversations. One, I guess I'd express some frustration about the argument that this isn't a problem that occurs that much, so why do we need to do anything about it? Because when we've had conversations that are problems that don't happen very much or anecdotal on the worker side, we prioritize making a fix. For example, we've done stuff about retaliation where we've said absolutely no employer would do that, and worker advocates said, well, we've had an experience where it happened, and so we passed a whole law to address that exact issue. So there was a commitment to have this conversation. I really hope that everyone will come into it with an open mind. And our goal here is just to make sure that all of the parties in this system are prioritizing getting the worker better and making forward progress. So the point is also to motivate the worker to prioritize that as much as everybody else. And that's having open-ended time loss without, you know, having the worker need to have a check-in with their doctor. It's just very concerning that you're going to see a stall in their recovery, and that you'll start 5 steps back from where you should have been had the worker consistently been seeing their doctor. Understand that there can be issues with scheduling, and I think if we all think creatively, we can find a solution for how to address that. But I do think that this is a serious problem that we need to figure out how to address. So just wanted to express that on behalf of our members. Thank you.
Thanks, Paloma. Giovanna?
Yes, thank you. I just wanted to respond to something. A few talks back, so I'll try to find that. Dr. Bowman did say that when he was asked that question about, well, doctor, seeing you, can't you help move things along? Isn't it helpful if you see the worker and they haven't been into physical therapy? Can't you do something about it? And he said, well, sometimes yes, but usually it's an authorization process. We all just have to wait for the authorization. So this idea that the doctor can somehow magically move the case forward, if they see them more often, is not necessarily the case. Also, when folks are waiting for surgery, they're waiting for surgery. I just had a client whose doctor requested physical therapy while they wait for surgery, and the MCO denied it, saying, you don't need any physical therapy until after your surgery. So these things are being attempted, and it's not always the worker refusing to go in and, causing the problems here. And I think that's, a broader issue that we've heard. I've heard a lot of things from everyone here about how everyone needs to be engaged, the employer and the worker and the provider. Yes, we agreed to have this conversation, and we have showed up every time with ideas and talking about the options. So I'm a little offended by any allegation that we're not here to talk about the problems, because we are. We don't have a predisposed idea about what's going on. When this was brought to us, there was an idea of a 30-day, and then immediately we were told that wasn't what the idea was anymore, and we were talking more broadly. So now we're talking more broadly. So, we're here to talk about options, and we're here to talk about options more broadly as well, not just what we see as could be a penalty to the worker to create a one-size-fits-all solution to a problem that has been dubbed as a very small problem affecting a very small amount of workers. It's not my words, those are Mr. Berenberg's words. So we are here to engage, but we have opinions on some of the things that have been brought forward. So there are less heavy-handed ways of doing this than creating a one-size-fits-all. There's no reason why an adjuster who gets what they see as an open-ended work release, why they can't write to the doctor and say, doctor, when's your next appointment? Can you quote, shouldn't this cut off on such a date? I see those all the time. The insurer is in a much better position to do that than the worker. The worker gets information from the doctor and reacts to that information. I have workers calling their doctors all the time saying, can you get me in? Can you get me in? And the doctor says, no, I don't have time. So this is something that everyone needs to be involved in. And if there's some particular engagement that you think we are not doing, I would love to hear it, because I feel like I've spent a ton of my time and effort being open-minded about these things and sharing and reading and participating.
Giovanna, may I respond? I appreciate your willingness to come to the table and your openness, so thank you for that. I think this subcommittee appreciates that. I do have a question though. You're saying a one size fits all, and I'm not sure I understand how limiting time loss to just not open-ended is a one size fits all. I feel like maybe the doctor would be able to determine that based on every situation.
I think if insurers do not want to have open-ended time loss authorizations, the question is where does, who does that fall on, right? So the doctor gives the worker, okay, come back to me after the MRI. Now, if there's a rule that says you have to have an end date on it, it doesn't matter when the end date is, you have to have an end date. Then what's the process there, right? Is suddenly there's an end date and the worker gets, cut off from time loss just because there's an arbitrary end date in the law, or is it on the insurer to reach out to the doctor? Like I believe in the only state that doesn't require open-ended, it said, I can't remember which state it was, but it said, if they get an open-ended, they send it back to the worker and the physician and ask them to fix it. Well, what happens to the worker's time loss benefits during that time? Those are the things that we are concerned about. If there's an open-ended one and then the insurers, gets to write to the doctor and say, hey, put an end date on that, that makes sense. But an arbitrary, all authorizations end after X amount of days, no matter what they say, no matter the circumstances, that's the one size fits all solution to a small problem that I don't think is appropriate.
Well, I think I read or I saw that like 7 out of the responses had not open-ended time loss. So I don't think that's one. 7 of the states. I may have looked at that incorrectly, but that's okay. Well, let's say just as an example, a worker is waiting for an MRI and the doctor says, yes, MRIs are backed up, in this person's head. I think it's going to take them probably 2 months to get in. So what if I put an end date and 90 days as a reasonable expectation in the system to ensure that they had continuation of care in that manner? Is that a one size fits all? I guess I'm just trying to understand better.
I'm sorry, in your example, you're suggesting a 90-day cutoff for all.
I just like if, let's say the doctor thinks an MRI is going to take 6 weeks. So to give a buffer, just like Dr. Lawler's example of they see everyone within a 60-day period, but they put 60 days there to give them that buffer to make sure that injured worker can be seen. If that doctor built in its own buffer to make sure the system could flow, is that a one size fits all?
That's a solution that works for that doctor and their practice. Dr. Lawler says she does things differently. Dr. Bowman says he does things differently, but acknowledge that his practice is different than like a podiatrist. So I would say that, we cannot, not all doctors are MCOs. We cannot, they have a hard time mandating to all the doctors that they have to do specific things and educating them on that and then educating the workers on that. So certainly that sounds like a really good practice. And if this committee could find a way to make every single doctor commit to that practice without increasing the paperwork to them and the burden on the system and making them want to withdraw from the system because of it, then we'd be talking about something. But in my view, any specific time loss cuts off on X date, regardless of what your individual doctor thinks is appropriate for your individual case, I think that's a problem.
I think that's what it is saying is an individual doctor would choose that date. So based on that practice and what would work for them, I didn't hear any specific date being laid out.
I would ask for the folks who are engaged in this, is there anything that prevents doctors from setting these dates currently? They can all do this now. They can say, we're going to do 90 days, we're going to do 60 days, we're going to do 30 days, we're going to do 15 days. Currently, there's nothing that compels a doctor to say, I'm going to leave it open-ended. This is kind of been on their practice, individual practice.
Yeah, that is my understanding. And I can say I look at work releases all the time. I see them every day and the things I look through, almost all of them are tied to a future appointment date or a specific number of dates. I don't see a whole bunch of open-ended ones. Those happen when the circumstances require them.
Okay, I guess I heard that there is some sort of an issue or problem on the business side, that from the Small Business Ombuds Office and others, that open-ended time losses are seen, and it is creating an issue in the system.
Sorry, it took me a second to get my my camera back on. You know, again, this is all anecdotal, right? At least on my side, because when it comes to the small business ombudsman, sorry, I have children at home. You can all hear. So this is all anecdotal. So when somebody calls and is you know, having questions about the system, it's not a lot of data that we're looking at. It's not like we're, you know, pulling a bunch of data that we're able to speak on a general vast basis, right? So we're having to look at it kind of case by case. You know, I guess I just wanted to point out that it could lead to issues with experience modifiers going up, cost of claims, and could cause you know, some monetary issues for smaller businesses if there is no checks and balances for how long people can kind of be out without having to at least touch base with their doctors. And I know there are some limitations now. They talked about the bug letter. And you know, there are those tools that could be utilized. So you know, I don't think that we have any, and I can't speak for Dave Walkie, he's not here today, but I don't think we have any specific time frame in which we feel like it's fair. I don't think 30 days is enough, knowing how long that it takes to get into a doctor, even for myself. But you know, the thought that the conversation needs to continue to be had about making sure that these claims are not just continuing to stay open due to lack of participation, not necessarily lack of availability of a doctor. That's a valid excuse, but lack of participation in the claims process in general. So, and I don't know if that needs to be a general rule that needs to be implemented, or just like Giovanna said, something that's a little bit more, not necessarily case by case basis, but not putting a blanket term on everything as far as like cutting it off at 30 days. If it needs to be more specific to, you know, different areas, that's fine. I guess I just wanted to point out that it could be a detriment to small businesses when they're trying to control their claims costs and control how much, you know, they're spending on workers' compensation and along those lines. But we don't have any specific opinion as far as like what that cutoff should be in a time as a timeline. I just wanted to make sure that the opinion was out there.
Thanks, Caitlin. Keith has had for quite a while, and then after Keith will be Kirsten.
You know, just a step back. I mean, I think that I know that we share the goal of keeping workers engaged in their treatment. I mean, nobody in the system benefits, us, our clients, anybody, when workers don't do what the doctors are asking them to do and stay engaged in their care. So, I mean, just to be clear, OTLA has no interest in coddling workers who are not trying to see their doctors and not trying to get better and trying to just stay on benefits. When I get involved in claims that go that direction, you know, I'm talking to my clients and trying to say, hey, you know, if you're not seeing the doctor regularly, if you're missing appointments, missing PT, that is not going to do you any favors in this process. But what we'd like to see, it's not, I wouldn't say that that's not a problem at all when it's happening. But what we'd like to see if we're going to take action is a more tailored way to address that problem when it's happening. Open-ended work restrictions presumably aren't a real problem as long as the worker is keeping regular appointments. It's the cases where the restrictions are open-ended and the worker is not keeping regular appointments for whatever reason, not doing what the doctor's asking. And you know, that's fine. That's a fine problem to address, but the solution needs to be more tailored and not just put all of the onus on the worker to police the doctor in terms of when appointments are happening, how work restrictions are given. What I would suggest is, you know, in those cases where this is identified as an issue with a given worker not engaging in care, you know, wherever that threshold may be for a given adjuster, you know, I mean, letters to the provider saying, hey, you know, this is really not a good thing. MAC says this is not a good thing to have indefinite open work restrictions and not see the worker and encourage them to follow up. Maybe that worker goes to both the worker and the doctor, so the worker kind of knows, hey, you know, we're seeing what you're doing. We're seeing that you're not engaged. We're telling your doctor that we'd like to see you more engaged. We're asking if that doctor can really verify your inability to work. You know, that is a targeted solution to this problem, to try and engage the worker, engage the doctor, educate both parties to address the problem. But again, just having, regardless of the date that's the cutoff date, you know, the question is whether the worker's getting back in and what the doctor's doing. And we would just like to see the doctor's decision and education and you know, things that the doctor's being told and asked to do, really driving the train here instead of the worker. Because say the worker's restrictions are 90 days, and say on day 90, the worker can't attend the appointment for good cause and good reasons. There's going to be circumstances where the provider cancels at the last minute, even after a 3-month period, or the worker for some reason really can't make the appointment, not because they don't care or don't want to, but just because it's not possible. And that's why we don't want a hard deadline that just applies regardless. But again, you know, this is all driven by the doctor and how quickly the doctor can see the worker, what the doctor's office practices are. And I would like to see the doctors who need to be educated about open work restrictions, you know, have that letter writing and that discussion with the doctor, instead of having a solution that addresses a lot of situations where the worker's not having problems with the doctor and staying engaged. So we're happy to talk about the problem and talk about solutions. We've been, you know, very adamant that we don't think a closed deadline on work restrictions that may not be well understood by the doctor or the worker, that may sweep up workers and harm workers that aren't part of the problem. You know, we've been very clear and vocal about why we don't think that's a good solution, but that doesn't mean that we're not open to other ideas or other ways to do this that aren't quite as heavy-handed, and try to look at that and see if it works, see if that addresses the concern and keeps workers more engaged, and see you know, how often we're needing to write bug letters or do different things to these doctors to say this is a problem. Then we have more discussion to go on to say, okay, now we need a broader solution. The solution we've tried isn't working. It's not working in these situations. It doesn't have to be data driven, but that still doesn't mean that you should not be tailoring the solution to the problem, as opposed to something that applies much more broadly. And I think that's what we have the most concern with on this whole issue. Thanks.
Okay, thank you. I just had a comment on your point of your example of let's say 90 days and then last minute they can't be seen. I thought we addressed that with a 45-day look back to help fix those issues and those examples. Do you feel that would fix that within 45 days, that a worker would be able to get back in if there's a last minute issue and cancellation on either side?
I think it helps ameliorate that issue, but still it's something that the doctor is doing or not doing that we're talking about primarily. We're talking about doctors who don't give work restrictions within reasonable intervals. And that should be on the doctor to fix, not on the worker to force the doctor to fix. If the insurers can't force the doctor or encourage the doctor or get the doctor to comply with what they'd like to see, how is the worker going to do that?
Okay, I'm unclear of how ending open-ended time loss isn't put on the doctor versus the worker.
The doctor is the one who's giving the restrictions.
Right. So if they're required,
following up when the doctor's asking them to follow up. And what this rule would say, regardless of the time frame, is regardless of what the doctor has said, time loss is going to end. I don't know why and how often a doctor would not, you know, be willing to see the worker or give work restrictions in reasonable intervals. But you know, if that's happening, the doctor needs to be contacted and the doctor needs to be asked to take some action, just the way the worker's asked to take some action. But it shouldn't be just cut off the time loss on a certain date. That's just not going to be well understood by by workers that whatever the doctor said doesn't really apply. It's this date, even though the doctor didn't say it that way.
Okay, Kirsten and then David.
So my comment was more to what Caitlin had been talking about. I wanted to kind of follow up on what she had said about the difficulty, particularly for smaller businesses. And I think another issue too to think about in that context is when you're dealing with a smaller business, these businesses are trying to figure out a way to, you know, make things work while this person is out, especially if you only have a staff of 5 people. You know, you're missing 20% of your workforce. And so, you know, I think that there's that, you know, she mentioned the financial piece, but I think there's also there is that incentive of why we feel so strongly about making sure that the worker is getting back to work is for the worker, and then also for the overall functioning of the business. And I think that that's where this idea of having a time loss that can be set by the doctor, as opposed to having a specific number set in statute, can come in that it's serving that purpose of getting what the doctor thinks is necessary for the worker, while also giving the business some kind of certainty of, you know, how it's progressing, and making sure that it's continuing to progress while they're trying to, you know, balance a lot of other things that might be up in the air while that's happening. So I just wanted to thank Caitlin for her comments and kind of add on to that a bit.
Thanks, Kirsten. David.
I wanted to get back to go in the Wayback Machine to Kirsten's original comments and then Keith's recent comments. I think that they were really, clearly we're having a contentious in a good way. I mean, you know, exchange of views on time loss and open-ended time loss and visits. And I think it's a good discussion. Going back to Kirsten's original add-on was, you know, maybe one thing we can do is also work with MAC and have some best practices, or, you know, and reach out and educate doctors in some ways. I mean, Keith's ideas too, you know, make sense to me. And, you know, we haven't had enough discussion, I think, on some of the more technical ways of using the system to address some of the issues. And are there ways in communication, education, expectations and standards that we should explore? And you know, I absolutely agree, and never mean to impugn, you know, OTLA. I think we clearly share the goal for the end results for workers, you know, on that. So, you know, I think, you know, still believe that having, well, comp is really interesting because every case is different, and there's flexibility in the system, but there's also a bunch of prescribed timelines and deadlines and expectations in the system. So it's how do you meld the two? And I think, as Keith talked about, who has responsibility and where do you place the burdens? And, you know, our thoughts on open-ended time loss, and yes, you know, a small number of cases. We still think that if somebody's having surgery and the doctor says we need to see you in 90 days or whatever it is, that is a date that then is known. And, you know, from the, we can even reinforce from the insurer's side that your time loss will end in 90 days or what have you. As Sarah has said, you know, there's the 45-day piece from last session. So we think, you know, that an expectation that there be some end date and some required connection makes sense. Though we're also, you know, as said, we'd go into this with an open mind, as did OTLA, to explore some of those other options and see what other ways we can try to make changes to the system that can better connect care to. And I don't have a good suggestion at this second of how we have that more technical discussion. Maybe there's a subgroup of the subgroup to go and talk about some of those. You know, you tell OTLA and us and MCOs to, talk, and the division to talk about some of those things and come back. Because I think it's hard just throwing those out, in this forum, and the nature of, I think the concepts are good, but the specifics are complex and hard to, talk about, in a broader group. So I'm not offering a solution yet, of how we have that discussion, but I think, those ideas that Kirsten and Keith put on the table are ideas that we should discuss and see if we can refine also.
I love that idea, David. What do you think, Matt?
Yeah, appreciate that, there's still a lot of discussion to happen on maybe more creative ideas and to go forward. Subcommittees on subcommittees always kind of cracks me up. That's what happens with nursing. It's like, oh, there's an issue, let's have a subcommittee, and then there's another subcommittee and whatnot. So
Matt, should we spend the last 15 minutes figuring out where to go next, Teresa?
Yep. That was my thought. Yeah, that was my next thing. You read my mind, was like shifting gears. So
we have a meeting next week that we have to respond to.
Yeah, it's just so I don't have the full agenda in front of me, but I believe it's just a status report to the full committee about the subcommittee.
That's on the 20th?
20th, yes.
Okay, and then we also have a charge to have a recommendation to the full committee at the November meeting. Is that right, Matt?
Mm-hmm.
Which is November 10th?
That is correct.
So we're coming against some pretty hard deadlines. So where do we feel we need to go from here on a very, very quick trajectory?
I would love input from Teresa on that. Yeah, those timelines are going to be, things are moving quickly.
Yeah, and I think it all boils down to how quickly I can get both of you a document and circulate the document about the synthesized all the ideas, conversations from the last 4 meetings together in a single document to kind of, again, narrow the scope of it as well.
I like the idea brought forth by David. If we can charge OLA Safe and the MCOs to get together, and if they can come up with some, I hear great collaboration and the willingness on all parties. I don't know how quickly they could get moving on that. If anyone wants to provide an opinion and a timeline for that, that would be helpful.
Yeah, that would be helpful to us too for scheduling, because I'm guessing we need at least one more meeting to go over things and discuss, the final recommendations of the subcommittee that would be presented to the full committee. The other thing too is that depending on conversations, not that I'm saying we want to kick the can on the subcommittee discussions and the great work that's happened today as far as next steps, but it could be that the 10th could be just kind of a status update of this is what the subcommittee is working on. Again, that would be up to the co-chairs to give the green light on, but it's the 10th is what's on the doc in the memo, but it's not. It theoretically could be moved. It's not set in stone.
It may be beneficial that the broader MLAC weigh in on kind of that next step, and we see what we present next week to the broader MLAC, and maybe we can use that group to make some determination on that.
That sounds good to me.
That works for me as well.
Okay. And then, so what we'll do is on our end for the next sub is we'll send some tentative dates to both you, to both of you before the 10th on that. And then I will work as quickly as I can. Hopefully I have some stuff to do this afternoon, but I will try and get a updated document to both of you by end of day Monday. And then from there, we'll tinker with it and then boil it down to a document that we can get circulated for Thursday.
Okay, that sounds great. On behalf of our subcommittee, and hopefully speaking for Matt as well, we appreciate everyone's willingness to come to the table and the open-mindedness and the inputs and the opinions set forth on this topic to come to a solution that is amenable to everyone. So thank you very much.
Thank you all very much.
Thanks, everybody.